Good morning, everyone. Myself, Dr. Manshika. My topic of presentation is capillary ferning on fundus fluorescent angiography, unveiling clinical phenotypes, and treatment response in posterior uveitis. Capillary ferning occurs due to excessive capillary or venular leakage in retinal vasculitis, peripheral fern-like leakage, and is an adjunctive indicator of uveitis activity. It can occur in both non-infectious and infectious inflammatory disease. In our study, we compiled 13 cases which showed capillary ferning and analyzed their clinical phenotype and treatment outcomes. Capillary ferning, according to Julian et al., implies Bessett's, but it's not a hallmark to Bessett's alone. Prithvi et al. Described an venular preference, and Dhurani et al. Showed peripheral capillary closure in TB and sarcoidosis. Our hypothesis is that venular inflammation leads to aggregation of inflammatory exudates, thereby causing occlusive episodes in small venular and capillary beds, causing backflow and extravasation of the dye, which leads to fern-like pattern. It's a retrospective analysis of 13 patients who have capillary ferning in FFA were analyzed. The history of presentation, systemic risk factors, previous treatment history, ocular examination, ocular investigations were reviewed. In FFA, we classify the capillary ferning into peripheral ferning defined by the area outside the vascular arcades depicted by the picture, and diffuse ferning not involving the macula, that is ferning present posteriorly crossing the vascular arcades not involving the macula, and diffuse ferning involving the macula. Our results, the mean age of presentation is 22 years with male and bilateral preponderance. The mean logMAR at final visit showed a significant visual improvement. The predominant etiology were Bessett's and TB, followed by intermediate sarcoid uveitis and Eales disease. The most common complications we encountered were secondary glaucoma and PSCC. Peripheral ferning and diffuse ferning involving macula were the most common presentation, followed by diffuse ferning not involving the macula. The visual acuity at presentation versus the FFA findings, more than 80% of them in diffuse ferning involving the macula had vision less than 6/60, and those who had good vision at presentation are in peripheral ferning and diffuse ferning not involving the macula group. Final visual acuity versus the FFA findings, more than 60% of those who in diffuse ferning involving the macula had poor vision less than 6/60, followed by peripheral ferning and diffuse not involving the macula had vision more than 6/60. That is, they have good visual prognosis. 60% required immunosuppressants and 38% required biologicals. Clinical activity at the end of follow-up, 60% were inactive in biologicals group, and 88% at the end of the follow-up who are in immunosuppressant with steroids are active at the end of the follow-up. This is a representative case 1, a 13-year-old with right eye blurring of vision since 6 months, and she had previous episodes of blurring and redness. She had past history of receiving steroids, azathioprine and MMF, and subtenon injection. His vision in right eye is 6.9 and left eye is 6.7.5. IOP is normal, and both the eyes showed anterior segment reaction, and fundus also showed vitreous haze grade 2 with peripheral vascular sheathing. FFA at the late phase had diffuse capillary ferning with disc staining at presentation. Her blood investigation showed HLA-B51 positive, and other investigation were inconclusive. And since the patient had recurrent and recalcitrant course, we switched to adalimumab 40 mg with prednisolone 5 mg per day, and at 1 month follow-up, her reactions were less, and there are no retinitis, and in third one follow-up, she had good visual improvement, and then the FFA showed reduction in capillary ferning at the late phase. This is a representative case 2, a 21-year-old presented with both eye blurring of vision since 1 year, previous history of right eye ERM surgery, and the patient was already on mycophenolate and steroids. Vision in the right eye is 660 and left eye 612. On examination, right eye anterior chambers were quiet and posterior chambers were also quiet. Left eye had vitreous cells with posterior subcapsular cataract. Fundus and OCT showed both eye cystoid macular edema. And FFA at first visit showed in late phase there is a peripheral capillary ferning with disc staining, and she was and her blood investigations were inconclusive, and she was referred to rheumatologist and was started on tofacitinib 10 mg. And on 3-month follow-up, her visual acuity improved to 636 in the right and 6.9 in the left eye with a quiet eye. And the fundus examination showed reduction in cystoid macular edema in both the eyes. Since, but there is persistence of CME. Since the tocilizumab acts well in uveitic macular edema, rheumatologist's opinion was sought, and and it was switched. And at third month follow-up, peripheral capillary ferning reduced with reduction in cystoid macular edema. Our take-home points are we conclude that capillary ferning occurs in papillary ferning in posterior uveitis occurs where disease course is severe, and diffuse ferning with macular involvement had poor visual prognosis compared to the peripheral ferning. An early introduction of immunosuppressive and biologicals in patients with significant capillary ferning causes good resolution of capillary leakage and visual improvement. Thank you.
So Manishika, you were having that tuberculosis also as an etiology.
Yes, sir. Yes.
So have you started ATT in those patients?
Yes, yes, sir. Along with ATT, immunomodulators immunomodulators and biologicals.
Okay. And any different pattern in those patients of TB? Because the pattern of that the disease in the base is different from that.
So they had a retinal vascular recalcitrant and recurrent. So we can switch over to immunomodulators and biologicals according to the patients.
And any other investigations? What investigations you have done for these patients?
Sir,
Whether any patient was presenting like that frosted branch meningitis or anything? No.
No, sir.
So have you ruled out virus or not in these patients?
Yes, sir. We have ruled out viruses also.
So what you have done?
We have done CBC. We have ruled out for TB, chest X-ray, quantiferon TB goals, sarcoidosis, ACE test.
Have you done AC tap or vitreous tap in those patients to rule out virus?
Yes, sir. AC tap was done.
AC tap was done.
Thank you.
Next, Dr. Jonathan.